Hello, this is Ileana Pina. We're talking today about the European Society of Cardiology meetings, which happen every year toward the end of August. And usually a lot of impactful papers are presented there that really do change how we treat and see patients and how we see the disease process. So this is my blog. I am thrilled to have a good friend with me today, Dr. Javed Butler, a good colleague, and chair of internal medicine at the University of Mississippi in Jackson. He's had some other hats before that, but this is his most recent hat, and obviously a very important one in an area where their research and the Jackson Heart Study is absolutely impactful and very, very important to what we know today. But Javed is going to talk to us a little bit more about HFpEF, heart failure with preserved ejection fraction, something that we have discussed before on this blog, and the frustration sometimes that we feel when trying to treat these patients because we haven't had that whopping great drug that we can say, this is it. However, we were very encouraged when we heard that the Emperor Preserve trial of Empagliflozin had reached its milestone and that it was positive. And so we were all very excited to hear about this. And Javed and our other colleague, Stefan Anker, have really been at the head of this. So Javed, welcome. A little longer introduction, but we've talked about this on my blog before about the importance of HFpEF and how we have never really nailed it, because I wonder if we're even talking about the same thing. So tell us a little bit about this and why this is so important and what is the drug?
Yeah, so thank you very much for inviting me. Great to talk to you. So this trial, Emperor Preserved, looked at SGLT2 inhibitor empagliflozin in patients with heart failure preserved ejection fraction, which was defined as EF greater than 40%. The trial was designed to answer 3 questions. So the power calculations and the design was for 3 questions. One, time to cardiovascular death or heart failure hospitalization, then total heart failure hospitalization, so first and recurrent, and third was renal function preservation or eGFR slopes. Having said that, obviously, while this trial was being done, science continues to progress. So there were a bunch of subgroups, although the trial was not designed for it. We did not necessarily have the power for it, but a bunch of the subgroups became really interesting in the field of HFpEF. So one is there a difference between 40 to 50 versus greater than 50? Because the data are coming out, looks like 40 to 50 is different than 50 plus. Then the other was the sex-based differences, that it looked like from some of the other trials that maybe HFpEF should be defined differently between men and women, and that maybe women respond more than men. So those are the kind of things. And then the issue of obesity comes up as well. So with that background, the trial was done, typical large trial, 6,000 patients, global trial. And what we found that the trial hit all its 3 predefined endpoints. So the time to cardiovascular death, heart failure hospitalization, 21% relative risk reduction, highly statistically significant. Total heart failure hospitalization, 28% relative risk reduction, again, highly statistically significant. And both of them, we will agree, is also clinically relevant, also 21 and 28% relative risk reduction. And then the eGFR slope also was significantly preserved, about 1.36 ml per minute per year. So overall, the trial achieved all the 3 goals that it was intended to look for. But then comes sort of the subgroup analysis that becomes of interest. So I say this with some reservation because these data are new. We really have to digest it, and we haven't done that completely. But the bottom line is that for primary endpoint, there was no heterogeneity noted on the basis of sex or on the basis of EF less than or greater than 50%. So that's good news that we may have a heart failure with preserved ejection fraction drug that works across the spectrum of these subgroups. However, we did not achieve the cardiovascular death benefit. There was a 9% directional benefit. It did not achieve a cardiovascular death, a clinically significant result. But I'm sure we'll learn a lot from secondary analyses of these data. Then DELIVER trial, the dapagliflozin will be coming out as well. So the dialogue will continue.
So, Javed, you brought out two very important points, and I was very happy to see that the effects seem to be very balanced between men and women. I think that that's a very important piece, since we know that the primary population of real HFpEF is women, and women that are very hard to control and very hard to get them feeling better even. I'm not surprised about the mortality, because what we're seeing nowadays is that a lot of these trials that we're seeing with a lot of different drugs affect hospitalization but do nothing to mortality. Maybe we have reached the best mortality benefit that we can achieve with what we've done before, and nothing new will come out of it, except that symptoms in this population is really, really important. So tell me a little bit about, and I'm going to ask you this, about the group over 50, because you did have some that are between that 50 and 60.
Yeah.
What about them?
Yeah, so there was actually a pretty sizable proportion, almost a third split between 40 to 50, 50 to 60, greater than 60, and the interaction p-value was 0.21, and the hazard ratio was less than 1 for all of these three groups. Now, obviously, as you go across the spectrum of ejection fraction, you start seeing the change that you have alluded to anyway. So you have more women in higher EF, less in the lower EF, more obesity in the higher EF, lower GFR in the higher EF group. So these are the changes that we really need to dissect a little bit more. I am sure when we get some time to digest these data, there's heterogeneity in HFpEF. Because the trial is positive in all subgroups doesn't mean that the heterogeneity goes away. I'm sure within this trial also there is heterogeneity, but we just need a little bit more time to digest and understand these things. But overall, we did not see a difference.
I think it's a very important group, because it's a group that we commonly see in the clinic. Again, many of them women, many of them obese, and many of them hypertensives that have had hypertension for years. And we make this diagnosis based on symptoms: the shortness of breath with activity. Obviously, if we could have catheters in, we could see how high these LA pressures go whenever there's some movement. And now we've been talking about cardiac rehab for this group with an important trial. And we've interviewed Delane Kitzman on this program as well. But this phenotype idea that people keep floating, we need to have phenotypes for HFpEF. What would you say to that?
Well, so first of all, phenotype with the strictest definition is what we sort of observe in front of our eyes. What we really need is to understand the various pathophysiologic pathways that drive the outcome. So it's a little bit of a different concept. And I think we will learn that so that we can have more targeted therapies. Obviously, the most obvious example is amyloidosis and how much we are learning. So, but the big question is, are there more such amyloidosis kind of hidden pathophysiologies that are different diseases within HFpEF? And I think we will understand a lot in this omics era, where we can understand the biology of the disease a little bit better. So that's one way of sort of thinking about phenotype. The other way of thinking about phenotype is that some people, based on all the comorbidities and demographic characteristics and whatnot, have a phenotype that is more likely to respond or less likely to respond. And that is sort of a no-brainer, that if you look across these groups of patients, of course, some people will be more advanced, less advanced, will have a mix of comorbidities that may be more or less responsive. And of course, that science will progress. So, but I do want to highlight that we use the term phenotype sometimes a little bit more loosely, and we mix these two concepts together.
Yeah. What about the weight? Did you exclude? Remember, Paragon excluded the very obese, which when I did Paragon, I couldn't get the patients in because all of my women in New York were obese. So what did you do with BMI and weight in EMPA?
We did have an exclusion criteria, and I think it was also 40, but I may need to check that. 40 or 45. I think it was 40, but we did exclude also.
Again, you and I have talked about this. I think that group, across all the trials that have happened, we need to look at that group of particularly women with those higher EFs, with that history of hypertension, with that obesity. And then a final question for you. Tell me about the aging of the heart. These are all older, and this group up there is in the high 70s. What's happening with just the senescence of the heart, the Ed Licata aging of the heart?
Yeah, so I mean, if you sort of think about it, all the therapies that have worked in patients with heart failure, with RAS modulation, aldosterone, and with beta blockers before that, none of these are really targeted therapies. They have really systemic effects and they improve outcomes. So when you come to SGLT2 inhibitors, while they may have been discovered as anti-hyperglycemic therapy, if you look at the entire pharmacodynamic profile in terms of its effects on the cardiac structure and function, in terms of its effect on the vascular structure and function, adiposity, and the renal function, all of these things get worse with aging. Endothelial function, aortic stiffness, fibrosis,
Compliance.
exactly. So all of these things, and SGLT2 inhibitors have beneficial effects on all of these things. So I'm not surprised that this sort of mixture of obese, older, and HFpEF populations that also have CKD benefit with SGLT2 inhibitors.
I also am always amazed when I see all the SGLT2 data across, is that we don't recognize often how much renal function the patients are losing until we do something like this, look at it across time. And the fact that there's preservation of renal function, to me, in long-term outcomes, maybe that's why the mortality doesn't really drop a lot, because we're not harming the kidney. On the contrary, we're protecting the kidney.
Well, but also, I mean, a couple of very quick comments. One is that at the end of the day, we don't have the appetite to do really long-term trials, right? So if you're going to look at the mortality benefit, this is not the 1980s, 1990s trial, which were powered only for mortality. These trials are kind of powered for combined endpoint, and the minute you hit the number of combined endpoints, which is largely driven by hospitalization, you stop. So that is difficult to say. And then, on terms of the sort of the renal function comments you made, I mean, it's a little bit humbling to say that there's a lot of things that we don't do in the clinical practice, and we don't screen, and we don't have the data. But this GFR business, I mean, every single patient that we see every single time has estimated GFR and electronic medical record, but we don't have that mindset to track the GFR and the decline and act accordingly. Having said that, there is so much interest in the field of CKD that hopefully that dynamic will change.
And I hope that the trial continues with long-term follow-up. I don't know if the group has decided to do that, but I think it would be very interesting to see, say, in a couple more years and 24 more months, what has happened to those patients. Yeah. I want to thank you for your time. I know it's a busy time for you. We have some very interesting papers coming out of the ESC, and I'm hoping to work with you on those higher EF patients as well. So Javed, congratulations to you and Stefan on a well-done trial, and the first time that we can say, that these groups really do benefit. I think it's a wonderful thing. So thanks for joining us, and to my audience, I hope that you can apply this to your practice. I hope that when you look at the patients, you look at them as individuals. We're all trying to practice precision medicine. And remember that stability is nothing more than an illusion in heart failure. Thank you for joining me today. Have a great day.